Welcome back, focused learners, to part 13 of our 15-part Interventional Radiology Coding Masterclass. In today's explainer, titled Into the Vessels, we are decoding some seriously foundational concepts. We're going to break down selective versus non-selective catheterization and really shine a spotlight on the vital components of supervision and interpretation, or what we commonly call S&I. Grab your notes, because this one is absolutely crucial.
Okay, let's dive into this. Here is our roadmap for today. First, an intro to interventional radiology. 2, surgery versus IR. 3, classifying IR procedures. 4, the vascular families. And finally, 5, a real-world clinical coding application.
Section 1. Intro to Interventional Radiology. To code correctly, we first have to understand what exactly goes down in the angio suite. Interventional radiology is a specialty that is completely 100% reliant on real-time imaging, things like ultrasound, fluoroscopy, CT, and MRI. Because the physician cannot directly see inside the body, this requires a specialized radiological service component called S&I, or Supervision and Interpretation. Now, S&I has two very distinct core components. Supervision is the real-time, on-the-ground oversight during the procedure. It's reviewing the patient history, confirming the protocols, and advising the procedural team to ensure the imaging is executed safely. Interpretation, on the other hand, is the thorough post-procedure analysis of those generated images. This is where the physician constructs a formal, written diagnostic report for the referring doctor. Section 2. Surgery versus IR. So how does this compare to what we typically think of as surgery? Well, traditional same-day surgery usually involves an open or endoscopic approach with larger incisions and standard anesthesia. Interventional radiology, though, relies on a percutaneous, meaning through the skin, approach. Instead of large cuts, IR uses tiny portals for specialized needles and catheters. Because it's so minimally invasive, the physician is essentially driving blind, relying entirely on that S&I image guidance we just talked about to navigate safely inside the patient. Which brings us to this foundational rule. It's a bit of a square and rectangle situation, right? All interventional radiology procedures fall under the broader umbrella of surgery. But obviously, not all surgeries are IR. Interventional radiology occupies a highly specialized, ultra-minimally invasive subcategory. Keeping this hierarchy in mind is super helpful when you're navigating the different procedural coding sections. Section 3. Classifying IR procedures. Now we're funneling down into how we actually categorize these procedures for billing. The very first major coding branch you need to figure out is this. Is the catheter inside the circulatory system, or is it accessing an organ directly? Vascular IR includes treatments strictly for the blood vessels. Think restoring circulation with angioplasty or stenting. Non-vascular IR focuses entirely outside the vascular system. It targets organs or tissues directly, like doing a fine needle biopsy or draining an abscess. Let's test this out with a quick interactive challenge pulled straight from our source material. Imagine you're reading an operative report, and you see this. Physician performed catheterization injection procedure for antegrade nephrostogram and or urotogram, complete diagnostic procedure including imaging guidance, and all associated radiological S&I. Notice that S&I is explicitly mentioned. But based on the procedure itself, which branch does this fall into? Vascular or non-vascular? If you guessed non-vascular, you hit the nail on the head. A nephrostogram targets the kidney, which is an organ, not a blood vessel. Because it completely bypasses the circulatory system, it falls firmly into the non-vascular category. The next crucial classification step is figuring out the intent of the procedure. Is it diagnostic or therapeutic? Diagnostic procedures are basically reconnaissance missions, identifying disease, where S&I is heavily focused on mapping out the anatomy. Therapeutic procedures are where we manage or actually treat the condition, like deploying a stent. Here, S&I is guiding the precise placement of that therapeutic device. Section 4. The vascular families. Let's see how this builds as we dive into the anatomy. We categorize these pathways into vascular families. Honestly, the best way to think about them is like major interstate highways with specific regional exits. You have the arterial family, which handles the blood supply, pushing oxygen-rich blood away from the heart. Then you have the venous family, managing blood returning back to the heart. And finally, the lymphatic family, which forms the essential pathways for the body's fluid and immune system. And this brilliantly illustrates just how complex the arterial network is. It spreads out like a giant tree, branching into smaller and smaller pathways. As a coder, You must know exactly which specific branch or order a catheter has navigated into, because that directly dictates the level of selective coding you're going to use. To help simplify that chaos, we systematically group these into major families. Here are 5 major arterial families you'll see all the time in operative reports. First, intracranial arteries supplying the brain. Second, carotid arteries feeding the face and head. Third, coronary arteries supplying the heart muscle. Fourth, visceral arteries branching off the aorta to supply internal organs like the liver. And finally, the lower extremity arteries carrying blood down the legs, including the iliac, femoral, and tibial arteries.
Section 5. Clinical Coding Application. Let's track a catheter's journey, and while we do, let's talk about a huge concept: dual physician or split billing scenarios. Imagine the surgical physician accesses the right femoral artery, advances to the abdominal aorta, crosses over to the left common iliac, and selectively places the catheter in the left superficial femoral artery. The surgical physician's role is performing the actual invasive vascular work: the access, the manipulation, the injection. They report the surgical CPT code for that. But what about the radiologist's role? They are the ones supervising that imaging in real time and performing the formal written interpretation. In this split billing scenario, the radiologist reports a completely distinct S&I code.
When it comes to the surgical physician's placement code, here is the golden rule you absolutely need to remember. You only code the furthest point reached within that specific vascular family. That final placement in the left superficial femoral artery automatically bundles up all those lesser first-order selections it took to get there. You don't code every stop along the way, just the final destination.
So how will you apply this rule of final placement and these split physician billing scenarios to your next complex vascular operative report? That officially wraps up our rundown of S&I fundamentals and catheterizations basics. Get ready for Part 14, where we will tackle Practical Operative Report Case Study 1, featuring a complete step-by-step coding breakdown. Thank you for watching, and keep learning with Decode Healthcare with Hartshal.